So picture this. You're in the ICU, and this chest x-ray pops up. Right away, you see it, a metallic pin, inhaled and now stuck deep in the left upper lobe. This isn't just some diagnostic curiosity, right? This is a serious problem that needs a hands-on solution. And this is exactly where the bronchoscope stops being just a camera and becomes a life-saving instrument.
Welcome, everyone. We're about to do a high-yield review of bronchoscopy in critical care. We've designed this specifically for those of you gearing up for your anesthesia finals, so we're going to break down exactly what you need to know to use this amazing tool safely and effectively. So here's our game plan. We'll start with the foundations, a little history and tech. Then we'll get into the clinical toolkit of indications, basically when to use it. After that, we'll take a tour of the airway anatomy, really understand the body's physiological response, and we'll wrap up with a practical checklist for mastering the whole procedure. All right, let's dive right in with the foundations. To really get a feel for the modern bronchoscope, it helps to see just how far this technology has come. We're talking more than a century of innovation here. It all kicked off way back in 1897 with Gustav Killian and a simple rigid tube. A few years on, Chevalier Jackson had the bright idea to add a light source. Pretty crucial, right? But the real game changer, especially for us in critical care, came in the 1960s with Shigeto Ikeda's flexible scope. Suddenly, we could navigate way deeper into the lungs. Then, fast forward to the 80s, and video integration just changed everything, making it the incredible teaching and clinical tool that we rely on today. Okay, so this lays out the two main players. On one side, you've got the rigid bronchoscope. Think of it as the heavy lifter, a straight metal tube that's your go-to for the really big stuff, massive bleeds, retrieving large foreign objects, or popping in a stent. But for pretty much everything else we do in the ICU, the flexible scope is king. That steerable tip is key, letting us snake our way down into those tiny little airways. Let's move on to the clinical toolkit. This part is all about the when and the why. These are the core reasons you'll be reaching for a scope, and they're definitely going to come up in your exams and, of course, in your day-to-day practice. The reasons we do this really boil down to a simple trio. We're either looking at something, taking a sample of something, or fixing something. It's inspection, sampling, or therapy. And if you look at this table, you'll see that a lot of common problems like aspiration or infection check all three boxes. We go in to look, to grab samples for the lab, and to provide direct treatment, like sucking out a nasty plug. Things like airway management or hemoptysis are more about just looking and fixing. And wow, this image just says it all. This is a perfect example of a therapeutic use. What you're looking at is a bronchus that's completely choked off by a thick, stubborn mucus plug. No amount of chest physio is going to budge that thing. But with a bronchoscope, you can go right in, see it with your own eyes, and suction it out to get that collapsed lung lobe working again. Now, a key sampling procedure you have to know is the bronchoalveolar lavage, or BAL. It's pretty straightforward. We gently wedge the scope into a lung segment, squirt in some saline to give the little air sacs a good wash, and then we suction that fluid right back out for analysis. This is absolutely the gold standard for diagnosing certain bugs, especially things like pneumocystis trevecii in patients with weakened immune systems. Right, now for the really practical part, the anatomy. Knowing the map of the tracheobronchial tree isn't just nice to know. It is absolutely essential for finding your way around and being sure about where you're taking your samples from. So let's take a quick tour using this fantastic diagram. We start up in the trachea, head down to the carina, that's the big fork in the road, which splits into the right and left main bronchi. The right side, you'll notice, is usually a bit wider and straighter. From there, it's like a branching tree into the lobar and then the segmental bronchi. You really need to know these branches by heart. Okay, exam brain's on. This mnemonic is pure gold and a total classic for exam questions. For the right lung, just remember APALM. APALM. And for the left lung, it's a little different, APAL. APAL. That's because the anterior and medial basal segments often join up. Seriously, commit this one to memory. And here's exactly why knowing that anatomy is so critical. This is a pretty common variation called a tracheal bronchus, or sometimes a pig bronchus. You can see a bronchus to the right upper lobe is coming directly off the trachea itself. Now, this has huge implications if, say, you're trying to place a right-sided double-lumen tube. Seeing it with your own eyes is the only way you're going to spot these little curveballs. So we know how to use the scope, and we know where we're going. But what is actually happening to our patient while all this is going on? This next section on the physiological impact is probably one of the most important things for you as an anesthetist to master.
Okay, so the single biggest physiological challenge is actually super simple. The scope itself is an obstruction. The second you introduce it into an endotracheal tube, you are fighting against a massive increase in airway resistance. It's a traffic jam in the airway.
And this number really drives that point home. 66%. Think about that. A standard 5.7 millimeter scope going through a 7 millimeter E-tube takes up 2/3 of the available space. That leaves very, very little room for gas to get in and out, which makes ventilating your patient a real challenge you have to be ready for. And that obstruction leads to a whole cascade of effects. First off, transient hypoxemia, a temporary drop in oxygen levels, is the most common thing you'll see. You'll also get hypercapnia because you just can't ventilate as well, a rise in intrinsic PEEP because the patient struggles to exhale fully, and reduced lung compliance. And on top of all that, the sheer stimulation of the procedure will kick the sympathetic nervous system into gear, jacking up the heart rate, blood pressure, and cardiac output. You have to be ready for all of it.
Now, after all those serious warnings, let's put the risk into perspective. Because despite all that physiological stress, bronchoscopy is actually a very safe procedure when you know what you're doing. The data shows that mortality is incredibly low, and the rate of any major complication is typically less than 2%. So, we've got the theory down. Let's finish up with the practical application. I want you to think of this last section as your pre-flight checklist, the kind of thing you run through every time to make sure the procedure is as safe as it can possibly be. This systematic approach is really your best friend. 1. Have a clear reason for doing it and get consent. 2. Fix anything you can fix beforehand, like check their clotting. 3. Get all your gear and drugs ready to go. 4. Optimize the patient. That means good positioning, deep sedation, and really thorough pre-oxygenation. 5, and this is so important, adjust your ventilator settings. You'll probably need to increase your pressure limits to push past that extra resistance. And finally, number 6, always have a clear plan for what happens after the procedure is done.
And here is a super critical, practical tip to take away with you. When you are sectioning, keep it short. No more than 3 seconds at a time. If you go on any longer, you risk literally sucking the air out of the alveoli, causing them to collapse, which just makes that transient hypoxemia we talked about even worse. So remember, short, sharp, and effective suctioning. That's the goal. And hey, if you want to dive deeper into any of this, all the information we talked about today came from this fantastic 2016 review article in BJ Education by Kabadai and Bellamy. I absolutely recommend it for your exam credit. So let's end with a final thought to take with you. Now that you really understand the profound physiological impact of this procedure, how would you adjust your ventilation strategy for a patient with severe ARDS who already has terrible lung compliance, compared to a patient with relatively normal lungs? Thinking through these kinds of scenarios is what really separates a good clinician from a great one.